Thank you for taking the time to learn about our newly developed diagnostic test for the recently discovered disease nephresis. The diagnostic test is called renal urine test, or RUT, and can play an important role in identifying potentially infected individuals to receive further testing. RUT is beneficial to patients by providing a less invasive, cheaper option to help determine someone's disease status. The test requires collection of a urine sample and can be quickly analyzed within a clinical setting. Before the development of RUT, the only other method of detecting a nephresis infection involved the use of imaging. As we know, these tests can be painful to our patients, as well as expose them to harmful radiation and are quite expensive. RUT will help save patients time and money while relieving them of the negative impacts of the only other diagnostic test. RUT should be used for screening patients. Testing should be done on asymptomatic patients who are suspected to have had contact with someone infected with nephresis. This will identify potentially infected individuals before they undergo the more invasive diagnostic testing. RUT has a high sensitivity and high negative predictive value, so it can be used as an impactful mechanism to triage patients before more invasive testing. RUT has a low specificity and a low positive predictive value, so patients should not be subjected to treatment from solely a positive RUT test. Our latest study on the accuracy of RUT was conducted with a population-based sample of 10,000 participants. The population included 1,400 diseased individuals, giving it a 14% prevalence rate. Collection of the participants for the study was done at random and is representative of the population of the United States. We believe the study has a high external validity and RUT would yield similar diagnostic accuracy seen in the study in populations across the country. The sensitivity for RUT proved to be 91%, and the negative predictive value was 91.5%. The threshold for RUT is established to ensure a high percentage of subjects with a nephresis infection test positive. There is also a high probability that a person who tests negative does not have the disease, which is shown through the high negative predictive value. The RUT test is not perfect, and false negatives were experienced during our study, but because of our screening protocol, we are able to detect a significant number of nephresis cases early, allowing us to treat these patients before they experience symptoms. Early detection fostered through RUT screening can prevent the disease from further spreading throughout the population. This test eases the burden of the more unpleasant diagnostic test for uninfected patients, and early testing can lead to improved outcomes for those who are infected. Patients who test positive in the RUT screen require further evaluation to determine whether they are infected with nephresis. Specificity for RUT is 15.8%, and the positive predictive value is 15%. This shows that the RUT screen requires further diagnostic testing to confirm the disease. There was a high rate of false positives for our screening test, which is why treatment should not be initiated prior to further diagnostic testing. Although the RUT screening does not diagnose the illness, it is an important test that leads to early diagnosis and reduction of morbidity and mortality. The RUT screening process poses no health threat to the patients, so there are few negative consequences for receiving it. Clinicians should make it clear to their patients that a positive screening test does not necessarily mean they are infected. If a patient tests positive in the RUT screen, clinicians should recommend they take the more invasive diagnostic test to determine if they are infected. If a patient does not test positive for nephresis during the RUT screen, clinicians should explain that the test is not perfect and encourage them to seek medical attention if other symptoms arise.